I will just start by a quick reminder on skin structure, and then skin model in cosmetic testing, and then future direction for research in skin models, and some example of use and some conclusion. So skin structure. So skin structure is composed of 3 layers: hypodermis, which is internal layers, which is reserved tissue and which is composed mainly of adipocytes. You have then dermis. Dermis is the support layer of the skin. It's composed of mainly collagen and elastin. There is a reticular dermis, which is the internal part of dermis, which is composed of big bundles of collagen, and the papillary dermis, which is mainly the role of papillary dermis is to ensure the nutrition of epidermis via the capillaries. So epidermis, which is the external layer, is responsible of the main function of the skin, which is to protect our body against external insults such as UV microorganisms, but also to avoid dehydration. This skin is composed of different layers. As you can see here, you have here the basal layer, which is composed of keratinocytes of high proliferative capacity, and the melanocyte is here in red, which are responsible of pigmentation of the skin. As you can see, melanin in brown. And these keratinocytes are differentiating until doing this part, which is the stratum corneum, which ensures the barrier function of the skin. Here are the different markers which are specific of the keratinocyte at the different layers. And for the barrier function, the main protein are filaggrin and loricrin. Here there is a description of cornified layer and how an ingredient active can penetrate into the skin via transepidermal or through the annex of the skin, such as the hair follicles. So which is important when you want to make an experiment on skin is the skin structure, but there is some points which are important, such as pigmentation, since according to pigmentation, the results can change. Here, you know that there is constitutive pigmentation, as you can see here, with a low phototype here and high phototype here, but there is also inducible pigmentation, mainly due to UV, as you can see here. And what is important to know between skin, here you have a low phototype skin, and here a high phototype skin, is the difference in the presence of pigmentation. Here in low phototype, you can see that pigmentation in dark, here in black is restrained to the basal layer, whereas in black phototype, you can see the pigmentation in all the skin layers. The difference is not the number of melanocytes, which is the same between all the patients. In this slide, you can see that the main difference between people is the presence of eumelanin, mainly in high phototype people. This eumelanin is found in eumelanosomes, as you can see here, which are big ovoid melanosomes, which can be found until the stratum corneum, whereas in the low phototype, you can see that the melanosomes are mainly polymelanosomes, which are made of many round, small melanosomes, which are easily degradable, and we don't find any melanosomes in the stratum corneum. Another point which is important is skin aging, because between aging, we have some numerous difference between patients. You can see here people which is young people, and during the time, you can see that there is a thinning of the skin, a linearization of the dermoepidermal junction. There is a decrease in the capacity of fibroblasts to secrete collagen. There is a decrease in the capacity of the barrier to allow the protection. So there is mainly dry skin when we are aged. So there is a lot of difference, and this is important when we want to choose the right model we want to study. So for the model, first I will just make just a short mention of the artificial membrane, which are synthetic membrane. So a simple polymer model or lipid-based model. There is a numerous commercial model, but the main model used is Stratem, which is made of polyolefin of various porosity to model stratum corneum, epidermis, dermis, and hypodermis. And this kind of synthetic membrane can be used to evaluate permeation, diffusion, and transdermal drug delivery. But in this model, there is no cells which are important between the comportment of different actives which will be integrated in the skin, in the cells. So to do model of skin equivalent, you need cells. So I show you here some picture of cells. You can see here keratinocytes, which are the main cells of the epidermis, and melanocytes, which are the dendritic cells. And in the dermis, the principal cells are fibroblasts and endothelial cells. There is also lymphocyte and pericyte, but the main use for the culture of the model are keratinocytes and fibroblasts. So just a quick overview of how we can make a skin. So there is different support I will detail after that, but you have mainly the support. On the support, you put a chamber or it's an insert. You put the cells, keratinocytes or melanocytes. You let adhere, and then you put them in submersion to allow the proliferation of the cells. And then you put in an interface air liquid named Ali to induce the differentiation of the skin. And here, after that, you obtain skin. Here you have a pigmented skin and a non-pigmented skin. This is to do reconstructed human epidermis, but you can do full thickness skin, which is made with a support where there is fibroblasts on it, which after that you have a phase to remodel the collagen matrix before adding keratinocytes and melanocytes. So this is the overview. And what is important to have when you reconstruct the skin is to have a fully differentiated epidermis with a stratum corneum. So for reconstructed human epidermis, RHE, you have many human keratinocytes which are cultured to form a multilayer differentiated epidermis. There is numerous commercial models made on polycarbonate, such as Episkin or Skinetics. So you can see here the basal layer, the differentiation, and the stratum corneum. These models are made on a rigid support, which change quite the quality of the epidermis. So there is model more interesting because there is a part which is more physiologic, such as this model, epiderm, which is made on collagen matrix. And on this, you can see that there is some recurrency. And there is another model, which is not commercial, but which is mainly used by a lot of groups, which is on dead epidermis dermis. Dead epidermis dermis is a support, is a skin which where the epidermis was removed and the fibroblasts were killed by thawing and freezing. But the importance in this model is that the dermoepidermal junction is maintained on your support. So it induced easily attachment of keratinocyte on it and allow a real nice differentiation of the keratinocytes. So these three models of reconstructed human epidermis with keratinocyte have different some difference you have to know when you want to do your experiment. If you want to do some experiment with only screening or something like that, polycarbonate filters are very easy to use. The environment is controlled. There is a lot of reproducibility. The barrier function, you can test it, but it's better with collagen or dermis, and it's cheaper. But there is less complexity. With collagen and dead dermis, you have a better complexity because you have this interaction between the matrix, but there is more variability. The cost is higher. It's more difficult to prepare, and there is some risk here of collagen of contraction. all this reconstructed human epidermis can be used for screening, for skin irritation, corrosion, cytotoxicity, skin differentiation, phototoxicity, to study the barrier, the water loss, or a lot of experiments, but you cannot test some effect on pigmentation and photoprotection. It's why we have developed some reconstructed human epidermis, pigmented epidermis, where there is melanocyte and keratinocytes. So there is also some commercial models, such as kinetic and melanoderm, and you can see here the pigment and the cells which are here, and here you have the pigmentation. But the better model is made on dead dermis, as you can see here, because here you can see that melanocytes have a lot of dendrite. So the attachment of melanocyte to the basal membrane is better in this model, and this model is more relevant to study pigmentation. But in this model, they lack the dermal part with the fibroblasts, which is the dermal part, and fibroblasts are very important because they are involved in control of different parameters, even pigmentation, but also for the cicatrization and the aging. So there is this model which were developed, which was on collagen matrix colonized with fibroblasts, with here keratinocytes. You can see that this model are more differentiated. The differentiation is better than in the reconstructed model without fibroblasts. You have this model which are commercial, such as epidermis and finium. And this model allow also long-term study because with fibroblasts we can keep them more longer in culture. And they can be used for skin absorption, toxicity, wound healing, and transdermal passage, which cannot be due on the reconstructed human epidermis, especially on polycarbonate filter. And there is another model which is more relevant and more physiological, which is ex vivo skin. So it's skin which is from the surgery. There is skin, like here, native skin, which is a commercial model, but you can obtain skin from surgical skin vest with some convention with hospital and clinic. And here you have all the cells involved in the skin. So you have the keratinocytes, the fibroblasts, the vessels, even if they are not functional, but you have them. You can have lymphocytes, and you have also in the epidermis Merkel cells and Langerhans cells. So they allow more due to their complexity, they allow a long-term study and to study metabolism, wound healing, the remodeling and the aging of the collagen matrix. They allow more numerous skin studies. So the future direction are skin on chip model, because this model are not, there is not the blood flow. So we wanted to have this kind of evolution in our model. To test drug, it will be better. So there is some development of organoplate, or like this, the microvascularized microbioreactor of Mohamed Dali. You can see here that we can have a flow inside the skin biopsy, which will be better to test drug delivery. Another advancement is 3D bioprinting skin model. So some startup which work on it, but it's very difficult to reproduce the skin in vitro, especially the epidermal part. For the dermal part, it's easy to put collagen in fibroblast in collagen in gel, which can be bioprinted, but for keratinocytes, it's more difficult. So, for instance, there is no commercial model. Another future direction, which can be personalized skin model with using the person-specific cell for personalized testing, which will be very important since there is very different behavior according to phototype, age, and microenvironment. and also the integration of additional component, incorporation of vascular and immune system element for more comprehensive model. Here you can see some vessels in the reconstructed skin on collagen matrix. So I will show you some example and model we can use. So here it's reconstructed human epidermis which mimic atopic dermatitis. So you can see here the normal reconstructed human epidermis. We test with a cocktail of cytokine and we obtain reconstructed human epidermis mimicking dermis atopic with the main feature, which is a decrease in filaggrin and an increase in carbonic anhydrase 2. And here you have two active compounds we have tested, and you can see that the active 2 is very efficient because we restore the filaggrin and we decrease the carbonic anhydrase 2. So this model, simple model with only keratinocytes, is very efficient to test some molecule which impact the filaggrin. For pigmented epidermis, you can see here some example using molecules which are the control molecule we use to activate tyrosinase. And here you can see with alpha MSH a great increase in pigmentation, and with acid kojic a great decrease in pigmentation as compared to the control. So this model are very useful to test hypo or hyper or whitening agent. For photoprotection, we can use this model, which are very efficient. As you can see here, it's a staining of DNA damage and used by UVB. You can see that with this cream, this sunscreen, we have no DNA damage, whereas with this one, there is some kind of DNA damage. What you have to know is that to test photoprotection, it depends if you want to screen some product or to test product which is finished, because you have this kind. Here you have a reconstructed human epidermis without melanocytes, and here with melanocytes. The reconstruction was made at the same time, irradiated with the same dose of UV. As you can see, 24 hours irradiation. Here you have a lot of apoptotic cells, which are sunburn cells, which are the hallmark of UV. And here with melanocytes, you see only one sunburn cell. So if you want to screen some product, you can use without melanocytes, which will be very efficient. But if you want to test the finished product, it's better to use the reconstructed model with melanocytes, because in the real life, we have melanocytes, except vitiligo and albinos people. We can also model some diseases which are more cosmetic, such as lentigo senilis, which is due to aging and UVB exposure. As you can see here, the black spot. In this disease, you have an increase in pigmentation in the basal layer and increase in the filaggrin content and loricrin, so dryness of the skin. And we have succeeded to reproduce this model using elderly fibroblasts we irradiated with UVA during 2 weeks. And as you can see here, after using this secretome, we observe that there is an increase in the retinal and an increase in pigmentation as compared to the control and to the non-irradiated one. And you have a decrease in loricrite, so a decrease in the permeability barrier. There is other model. So this is a model also to mimic aging. It was used on collagen lattice with collagen with fibroblasts, as you can see here. This model is less effective than the one on DDD, on dead epidermis, because you can see here that there is less attachment between the epidermis and the dermis. As you can see, when you increase the percentage of fibroblasts, senescent fibroblasts, so old fibroblasts, you have a decrease in thickness of the skin. and you have a decrease in filaggrin. We can also use the ex vivo model to mimic some disease such as melasma. Melasma is observed in women, pregnant women, or in men using new start. It's a pigmented area on photoexposed skin, mainly on the face. And you can see that using UVB and estradiol, we observe that we have an increase in pigmentation and a change in the melanosome shape, which look like what we have in melasma. Whereas you can see here you have polymelanosome and here single melanosome. So we reproduce the melasma, and with this model we can test some molecules which could act on melasma. The model, ex vivo model, is also very efficient to test some molecules which are using for wound healing. We make a wound with a biopsy punch. As you can see here, there is no epidermis, and after some days, you can see that there is a reepithelialization of the wound. I show you that we need pigmentation to study whitening agent or hyperpigmentary products, or to test photoprotection. But we can see here that when we have melanocytes, in this model of reconstructed human epidermis mimicking atopic dermatitis, you can see that when you have melanocytes, the model is less relevant. You have still expression of filaggrin. We have no this expression, this high expression of carbonic anhydrase 2, and we have also still expression of cadherin. So this model of reconstructed human epidermis to mimic atopic dermatitis is more relevant if you want to screen some molecule without keratinocyte, without melanocyte, and it is the same when we want to compare this model to the ex vivo model using the same cocktail of cytokine. You can see that there is not this increase in CA2 in this model, and you have still some expression of filaggrin. So the model of reconstructed human epidermis with keratinocyte alone is better to test this kind of molecules. So in conclusion, you have these different models. We have to choose them according to what you want to do. If you want to screen some molecule, if you want to test something in the dermal part, you need to have full thickness model or ex vivo model. If you want to test pigmentation, you need melanocyte. But if you want just to screen, this model is sufficient. Knowing that this model on RHE, mainly on polycarbonate filters, are very reproducible, are highly controlled, whereas this one are more complex, more variable, and you will need more experiment to know if your molecule is effective than in the model using polycarbonate filters. So in conclusion, we need to develop more models to be more relevant, to have cosmetic tests which are more relevant to all the molecules we want to develop. And the most important is to choose the right model according to the active ingredient, the effect of the active ingredient you want to test, the RHE on polycarbonate for the screening of the molecules, the one on collagen or dermis, you can make some experiment on aging, action on basal membrane, with pigmentation, with melanocyte pigmentation and photoprotection. Full thickness skin and ex vivo model we can keep them with longer time. You also test some molecule in chronic. It's better to test to use them. You can do wound healing, and you can analyze some action on basal membrane. Thank you for your attention.